I would like, okay. Um, Good evening, everyone. I would like to introduce my dear colleague, Dr. Saud. He is a nephrology consultant in Royal Hospital, and he is one of the rising star in nephrology world, soon, inshallah, in Oman and everywhere in the world. And he will discuss with us renal syndromes in nephrology. Please, Dr. Saud, you have proceed.
Thank you, Rami, for such a glowing introduction. I don't know if all of it's true. So, assalamu alaikum, everybody. Today we'll be talking about renal syndromes. As Dr. Rami said, it's an elusive topic to us nephrologists, and a lot of us, we tend to learn it and then we tend to forget it, and we don't tend to understand it, or sometimes we understand it and we forget it as well. So hopefully this end of this presentation, you will have a better understanding of the mechanisms and pathophysiology of these conditions. So to better understand the condition when you see the patients in front of you with it. So as you know, my name is Saud Laiq, and let's start the topic. So we have to go back to the basics to understand it deeply. As you can see in front of you is the structure of a hepatocyte. No, it's a nephron, of course, you all know that. So there's a few channels that we need to know, and that we'll be focusing on as per view of this lecture. So the first channel here is the sodium-potassium 2-chloride channel, which is present in the thick ascending loop of Henle. Of course, the function of this channel, as you can see, is reabsorption of sodium, potassium, and chloride. And along with it, it helps pull water back in as well into our body. So this channel also helps in maintaining a very important voltage gradient, which basically helps in reabsorption of calcium in the proximal segments of our nephron. The second channel that we'll be talking about is the sodium chloride pump, which is present in the distal convoluted tubule. As you can see, it reabsorbs sodium and chloride. The last but not the least channel that we'll be talking about is the ENaC channel, the epithelial sodium channel. This is an aldosterone sensitive channel. As you can see, it's an active channel that helps in reabsorption of sodium, creates a gradient which drives the excretion or the secretion of hydrogen and potassium ions. The potassium ions is not by this channel directly, it's by actually the ROMK channel, but it helps in putting the voltage gradient to drive that in. So the ROMK channel, as you all know, is the renal outermedullary potassium channel. So the first syndrome that we'll be talking about is the Bartter syndrome. So hopefully those channels have given you a better idea of what we'll be talking about further in the further slides. This is an autosomal recessive condition. Many specific gene mutations, various gene mutations are responsible for this condition. Many of them are known and we can do studies for them. So the issue here, to the crux of the matter, is a loss of function mutation in the first channel that we talked about, the sodium-potassium 2-chloride pump, in the thick ascending loop of Henle. As you can see, this channel has a loss of function mutation here. And along with it, you have loss of two more channels, which is the chloride channel as well as the ROMK channel in the same thick ascending loop of Henle. As a net result of the loss of these function of these channels, less reabsorption of ions leads to less reabsorption of water. So there is a low volume or low blood pressure state because excess urinary losses. This, of course, this low volume and low blood pressure state activates our well-known RAS system. Namely, the component here that's important is the aldosterone axis, which is activated. And of course, as you all know, the aldosterone axis will drive as we discussed in the previous slide as well, increased hydrogen and potassium excretion via the ENaC channel. So this results in a net metabolic alkalosis with hypokalemia. Now, the other effect that we see here, because of the loss of voltage gradient to a net negative in the tubular space, that results in a net negative charge, and because of that, there is a reduced voltage gradient for reabsorption of calcium in the proximal segments of the nephron. That results in reduced reabsorption of calcium and thus more excretion of calcium, which is hypercalciuria, and as a result, hypocalcemia. So this chloride channel, which is unfortunately also present in other parts of our body, namely the inner ear hair cells. responsible for sensory neural functioning. So this channel, as it is a genetic condition and it is present all throughout the body, would also result in sensory neural hearing loss because of the chloride loss in the inner ear cells. So as you can see, this syndrome has what I've highlighted in green: metabolic alkalosis, hypokalemia, hypercalciuria with hypocalcemia, and sensory neural hearing loss, which you see in many of our patients. The next syndrome that we'll be talking about is Gittelman syndrome. Again, this is an autosomal recessive condition. There are many different specific gene mutations. The issue here is the loss of function mutation in the sodium chloride pump in the DCT. So that's the urine direction, and you have sodium and chloride channel inhibition or loss of function mutation there. In the same space, you also have another important channel that is also inhibited, and there's a loss of function there, which is known, namely the TRPM6 channel. That's responsible for the majority of magnesium reabsorption that happens in our tubules. So there's a loss of function there as well. Of course, due to inhibition of sodium and chloride reabsorption, there is increased water as well, because water is also not being reabsorbed. So that results in polyuria, again, resulting in a low volume or a low blood pressure state, again, resulting in activation of the ROS system, and the aldosterone system would again cause increased hydrogen and potassium excretion. So same as in Bartter syndrome, you have metabolic alkalosis with hypokalemia. The other thing that you see here is, since there is reduced reabsorption of magnesium, you have hypomagnesemia. Now, magnesium, as you all know, is required for the chief cells in our parathyroid gland to help in release parathyroid hormone. So since those are inhibited, PTH is inhibited, that results in hypocalcemia. Now, as a net effect of this resultant hypocalcemia and the low volume, low blood pressure state, there is an increased reabsorption of calcium in the proximal convoluted tubule, basically hypocalcemia, so you need to reabsorb more. And also because of the low volume, low blood pressure state, and the defect being in the distal parts, so you have more requirement for reabsorption of water in the proximal segments. So since more requirement of absorption of water, along with that, calcium is also being pulled in. So you have hypocalciuria because calcium is being pulled back into the circulation to compensate for the hypercalcemia. So this is in contrast to hypercalciuria, which we saw in Bartter syndrome. So how do we make the final diagnosis? So you suspect that, of course, in a patient that comes to your clinic with an unexplained hypokalemia, metabolic alkalosis with a low or normal blood pressure. This is what we normally see in our patients. Of course, we need to exclude differential diagnosis like surreptitious vomiting, diuretic use or abuse, and the lab test that would help in confirming that they have, in fact, a tubular defect that is causing Gittelman or Bartter's would be measuring the urine chloride, which is almost always high. Distinguish between the two conditions with urinary calcium. As we discussed, in Gittelman, there is hypo, and in Bartter's, there is hypercalcemia. Of course, confirmation of all these conditions, both of these conditions, namely, is genetic testing, and a lot of the gene mutations are already known and identified. The management of these conditions. So how will you treat these patients? So of course, you have loss of electrolytes. So the most logical answer would be to replace the electrolytes, and that is what we do. That's the mainstay of management, is by replacing sodium chloride salts, potassium chloride, or magnesium salts as needed, as they're lost, as measuring in the serum. Before moving on to second line, we should always ensure compliance, because these are genetic conditions, and our patients who have Gittelman and Bartter tend to have some level of intellectual impairment, not all, but some or most of them. And the compliance can be an issue in these people. So always confirm that they're actually compliant to the level of salt replacement that you're giving them. And of course, if you can confirm that they are compliant, or basically or you're requiring very high doses which cannot be accomplished, then you can add on potassium sparing diuretics. However, you have to take care that these medications are known to cause low blood pressure, and our patients are already, unfortunately, burdened with low blood pressure. A medication of interest is indomethacin. This was Used in the past, some nephrologists still use it. However, of course, we as nephrologists know that NSAIDs can be problematic, especially as a long-term medication. So we tend to generally avoid it. Of course, it can still be used in really, really resistant conditions, but of course, with very, of course, with very close follow-up. Another point to note, of course, to these patients is very important, is if your patients tend to get pregnant while having these conditions, you should know that the requirements will be higher. So whatever amount of salts that they're on, you should consider increasing it as soon as possible. The conclusive management for this condition is to replace the kidney itself, which hopefully a kidney which doesn't have these tubular defects. So, of course, that we cannot do in all patients. That's reserved for patients that end up end stage with these conditions, and that's basically a corrective procedure for them. The third condition we'll be talking about is Liddle syndrome. It is an autosomal dominant condition. Over here, the issue is a gain of function mutation in the ENaC channel in the collecting duct. So, as you can see, due to the gain of function mutation, you will have increased sodium reabsorption, and as a result, increased water reabsorption that results in high blood pressure. Now, as in contrary to the previous syndromes that we discussed, there will be a negative feedback to the RAS system that results in hyporeninemia and hypoaldosteronism. As you can see, there is increased hydrogen potassium excretion because there's increased sodium reabsorption, and that results in metabolic alkalosis and hypokalemia, because you're losing more potassium and you're losing more hydrogen ions. So the diagnosis, again, of Liddle's, you suspect it in a patient that comes to you with hypokalemia, metabolic alkalosis, but instead you have over here hypertension. And of course, when you do their blood tests, you will find low plasma renin and aldosterone. Confirmation, again, is with family history, because this is a genetic autosomal dominant condition, so it will be predominant in many members of the family, and also, of course, genetic testing to establish diagnosis. The management of this condition is, of course, not salt replacement. It is, you have to inhibit the actual channel that has a gain of function mutation. So you supplement with direct inhibitors, which is amiloride and triamterene. Spironolactone is not effective. Can anybody tell me why it would not be effective? Anybody still awake while I'm talking?
Yeah, close the talking for them. Because actually it work على aldosterone receptor epithelial sodium channel only specific by amiloride and triamterene.
Correct, exactly. So, because the issue here is the ENaC channel, and spironolactone is not going to work on the ENaC channel. It's only going to inhibit the aldosterone, and no matter what level of aldosterone you have, you still have this gain of function mutation, and the ENaC channel is just going to continue doing its job irrespective of the aldosterone levels. The next condition is pseudohypoaldosteronism. This is an autosomal recessive condition mainly. There's a loss of function mutation in the ENaC channel in the collecting duct, just the opposite of the previous condition, Liddle's. So there is, of course, the opposite. There is low sodium and water reabsorption. There is, again, low blood pressure that results in metabolic, and because of the low blood pressure, there is inhibition of the RAS system. But in any case, over here, the issue is there is reduced excretion of hydrogen and potassium because of the loss of function mutation in the ENaC channel. And that results in metabolic acidosis and hyperkalemia. So the treatment here would be, of course, since you're losing sodium in the urine due to lack of reabsorption here, so you have to replace that sodium. So that's a high salt tide. And of course, you could try fluorocortisone, because you can see this is the issue is loss of function mutation in the ENaC. So you could try stimulating it as much as possible by using an aldosterone agonist, like something that will basically hopefully push this channel to work harder. So that can be trialed as well. The next condition that we'll be talking about is Gordon syndrome. That's pseudohypoaldosteronism type 2. Over here, the issue is a gain of function mutation in the sodium chloride pump in the distal convoluted tubule. So due to this gain of function mutation, you have a reduced sodium delivery to the collecting duct, because you are reabsorbing a lot of sodium from this DCT. And as a result of the reduced sodium delivery to the collecting duct, which is the next part after the DCT, as you all know, the ENaC channel gets deactivated because the ENaC channel loves sodium, and if it doesn't have enough sodium, it's going to stop working. So as it stops working, there is reduced sodium reabsorption. As a consequence, there is reduced excretion of potassium and hydrogen. Due to that, we have metabolic acidosis and hyperkalemia in this condition. The treatment would be something that would inhibit this channel as much as possible because of the gain of function mutation. And the channel, the drug that you all know that inhibits and works at the distal convoluted tubule is hydrochlorothiazide. So thiazides are the mainstay of treatment in this condition. So to recap, you have the sodium-potassium 2-chloride channel in the thick ascending loop of Henle. A loss of function mutation here is Bartter syndrome. Then you have the sodium chloride pump in the DCT, which is loss of function is Gittelman, and a gain of function is Gordon's. Then you have the ENaC channel, where a loss of function mutation would result in pseudo-hypoaldosteronism, and a gain of function mutation would result in Liddle syndrome. So what would be your approach when a patient comes to you? You assess with the blood pressure. If the blood pressure is low to normal, of course, this patient is coming to you with symptoms of fatigability, and of course, well known, he's having some sort of potassium disturbance. So when you have low normal blood pressure and you see metabolic acidosis with hyperkalemia, you're thinking pseudo-hypoaldosteronism. When you have metabolic alkalosis with hypokalemia, that's when you start thinking a bit more. So you measure the urine calcium, and when it's higher, it's most likely Bartter syndrome, and when it's low, it's Gittelman syndrome. This is most likely. It's not something that's set in stone. The blood pressure when it's high, and you have metabolic acidosis with hyperkalemia, it's Gordon syndrome, and when you have metabolic alkalosis with hypokalemia, it's Liddle syndrome. So for our purposes and what we see in not common clinical practices, we need to distinguish between the three, which is Bartter, Gittelman, and Liddle. The other two conditions are quite rare. So we're coming to the end of our lecture. I hope you have all have a deeper understanding of the channels and why these conditions arise because of the defects in these channels. So let's come to an MCQ. Hopefully, we can get all the answers right. So we have a 16-year-old boy. He comes to you complaining of fatigability and weakness. He has no other complaints. The physical exam shows a normal blood pressure 118/70. His heart rate is 72. There are no orthostatic changes. There is no edema. Rest of the physical examination is mostly unremarkable. The labs show a sodium that is 135, which, as you know, is normal. Potassium is 2.5, which is low. Chloride is 85. Bicarb is 38, which, as you can all see, is high. The urine sodium is 80, which is high. Urine potassium is 70, which is again high. In further history, he's a very open individual, so he gives us deep history. He says his older sister has some issue, and she takes medications daily. He doesn't know what her issue is and what medications he's taking. However, he does mention he has tried some of these medications in the past to see if the medications were of any recreational value. Basically, he thought that maybe if she's taking it daily, it will help him get high or something, but maybe it worked, it didn't work, we don't know. So the question is, why does he have hypokalemia? What do you all think? The choice A is cyclical vomiting. Choice B is diuretic abuse. Choice C is either Bartter or Gittelman syndrome. D is none of the above, and E is all of the above if possible. Anybody?
Well, it definitely cannot be vomiting, Saud.
Yes.
Bartter and Gentleman, you need the serum magnesium and the urinary calcium, which
Correct.
is least more likely.
Yes.
Diuretic abuse, of course, you know that Bartter syndrome is furosemide-like syndrome, and Gentleman is thiazide-like syndrome. So it will go more or less with Bartter or Gentleman.
Agreed. I mean, he's very open with his history. So if he was abusing diuretics, he would tell us. He just said he used it once in the past. Cyclical vomiting, there's no history. And so it's most likely barter-urogytal. What test will help us make this diagnosis? A spot urine potassium, a spot urine sodium, a spot urine potassium creatinine ratio, none of the above, or any of the above? There's some answers in the chat. Thank you,
We can
Dr.
go through
Saud.
the chat question and then we can discuss this in open.
I think you already give us the urinary potassium and the urinary sodium. The urine potassium to creatinine ratio, I don't think it will be of value here.
Right.
My opinion is none of the above. We need urinary chloride and urinary calcium to differentiate.
Excellent. Thank you, Dr. Saud. So if you were paying attention to my lecture, you would know that none of these are important. And thank you, Saud, for the correct answer. So it's none of the above. You would need urinary chloride to see that it's either of the condition, and a urinary calcium to help differentiate between each of the conditions. So which salt would you use to treat, let's say the patient has Barter's urogytal? Would you use potassium acetate, potassium citrate, potassium chloride, none of the above, or any of the above? Oops, sorry.
So why you need to treat the potassium alone here?
No, I mean, which salt will you use to treat
with
his
salt.
hypokalemia? Because his current condition is weakness, fatigability, and I think the most disturbed electrolyte is potassium.
Well, we do not use the acetate, and the citrate is the wrong treatment for this condition. So
chloride.
yes, Allah is right.
Perfect. So because these patients are already having an element of metabolic alkalosis, so using either acetate or citrate will exacerbate that alkalosis. So chloride would be the correct answer. That's correct. All right, that's the end of my lecture. Thank you, everybody.
Thank you, Saud. Excellent lecture.